Good
Good
morning.
Oh, hi, good morning. It looks like we're back. Good morning, everybody. We're back from break. This is Desma Rozovics. I'm with the Illinois Academy of Family Physicians, and it is my absolute honor and pleasure to be able to introduce our next three speakers. And I'll also be introducing the moderator for the Q&A for the next three talks. So up first, we have Melinda Neuhauser. Melinda is a pharmacist in acute care. She's a pharmacist and acute care lead for the CDC, the Office of Antibiotic Stewardship, and the Division of Healthcare Quality Promotion. Melinda graduated from the University of Minnesota, go Gophers, from the College of Pharmacy, completed infectious disease residency training at Detroit Receiving Hospital, and had fellowship training at University of Illinois at Chicago. Go Flames! Prior to joining the CDC, Melinda worked as a National Clinical Pharmacy Program Manager in Infectious Diseases for the Department of the VA for the Pharmacy Benefits Management Services, and she was co-chair of the VA National Antimicrobial Stewardship Task Force. She has also previously worked as a clinical pharmacy specialist in infectious diseases at the National Institute of Health Clinical Research Center, as well as the University of Houston College of Pharmacy at the Anderson Cancer Center. At this time, I'm also going to introduce Dr. Raj Mahajan, who will be moderating all three of the next Q&A sections. Dr. Raj is CEO, founder, and president of Chicago Internal Medicine Practice and Research, also known as CIMPAR, and he leads its affiliates group of companies. Dr. Mahajan is the Clinical Associate Professor of Medicine at the University of Illinois at Chicago. Once again, go Flames! Clinical instructor of Rosalind Franklin University of Medicine and Science, and also attending physician in the Loyola University Affiliated Geriatrics Fellowship Program at the Hines VA Hospital. He's the section chief of geriatrics in the Illinois Masonic Medical Center. He is a fellow of American College of Physicians and board certified in internal medicine and geriatric medicine. Additionally, Dr. Mahajan is a certified medical director, a certified physician advisor in utilization review and healthcare quality management, and is certified in infection control and epidemiology. Dr. Mahajan serves on several technical expert panels for the Centers for Medicare and Medicaid Services. During the COVID-19 pandemic, Dr. Mahajan advocated for on-site vaccination programs for the most vulnerable seniors in congregate setting, and his company, CIMPAR, became one of the most largest mobile vaccinators for low-income senior housing and nursing homes in the Chicagoland area. So without further ado, I hand it over to Melinda Neuhauser.
Great. Can you hear me?
Sure can. You sound wonderful.
Oh, wonderful. Well, thank you for the kind introduction and opportunity to present today on the CDC updates for stewardship. Definitely looking forward to when we can all be face-to-face and not have any technical issues. But let me know if my slides aren't advancing, or please interrupt me if you can't hear me or ever any issues. Today, I'm going to mostly focus on the hospital setting for antibiotic stewardship in light of our updated hospital core elements being released in November 2019. This is kind of a disclaimer. This is going to be a non-COVID focused lecture, as Dr. Sarah Kabani and I will present later this morning on antibiotic use during the COVID pandemic. And then Dr. Kara Jacobs from CDC will also be presenting on COVID-19 vaccine for LTC residents and staff in afternoon session. I have no financial relationships or disclosures. And I think many of you have seen this. This is the updated threat report that was released in 2019. The CDC estimated that almost 2.9 million illnesses and over 35,000 deaths each year occur due to antibiotic-resistant infections in the U.S. And also over 200,000 cases of C. difficile infection and almost 13,000 deaths occur each year. Ensuring appropriate antibiotic use is one of the CDC's 5 core strategies to combat the threat of antibiotic-resistant infections. So you can see here outlined in the threat report, antibiotic use and access is one of the core strategies, along with infection prevention and control, environment and sanitation, tracking and data, and vaccines, therapeutics, and diagnostics. There are many opportunities to optimize antibiotic prescribing. This is a recently published analysis on a prevalence survey that was conducted in 2015. So it was recently published, but it was actually data from 2015 that reviewed the appropriateness of 4 common prescribing events in hospitalized patients. So it was 2 infections, CAP and UTI, and then the class of fluoroquinolones and IV vancomycin. And overall, half of the antibiotics prescribing for these selected events was not consistent with recommended practices. Examples of what would make it not recommended practices: if too broad of empiric therapy, for example, for CAP, or too long of a duration, or if there's a bug-drug mismatch. And then if you can see in the pie charts, prescribing was not supported as high as 79% of patients with CAP and as low as 27% for patients receiving IV vancomycin. I think many of you know that the hospital core elements of antibiotic stewardship framework, CDC originally released in 2014, and then we updated in 2019. And the core elements outlines the structural and procedural components that are associated with a successful stewardship program. And the 7 core elements are hospital leadership commitment, accountability, pharmacy expertise, action, tracking, reporting, and education. And although these were released in November 2019, I thought for today's update, we really could focus on some of the updates to these core elements in light of soon after these were released. Of course, we all were quite busy with COVID. And as you think about maybe really focusing back on more traditional stewardship activities, thinking some of the robust examples that we provide here, how to enhance your program, I thought I could further discuss. The first hospital core element is the hospital leadership commitment, and we know this is dedicating the human, financial, and IT resources. When we had spoke with individuals, stewards, that when we were updating the core elements, they felt that this really needed to have more of a priority examples to engage the C-suite more. So rather than more checking the box with a newsletter and the updated core elements, we outline priority examples. So this is the first time that we really highlight priority examples in the core elements. And the ones that we highlighted were to increase engagement with leadership, such as having regular meetings and reporting stewardship activities and outcomes. And also having a champion within the C-suite to ensure that the program has resources and support to accomplish its mission. And I think this is not just important for hospital, but can definitely be applicable to other settings such as nursing home and outpatient. Accountability is our second core element, and this was updated to really emphasize the importance of co-leaders. And that originally was more focused on just having a leader. But we found that most hospitals found that the co-leadership model with the physician and pharmacist to be effective. And as you can see in the bar chart, the co-led programs in orange have increased from 2015 to 2019 in hospitals reporting to NHSN Annual Hospital Survey. Pharmacy expertise, previously called drug expertise, is the next core element. And we know that highly effective hospital stewardship programs have strong engagement of pharmacists and ideally co-lead the stewardship program. And CDC developed posters for hospital pharmacists highlighting 5 key stewardship interventions. And this is not just for stewardship or ID trained pharmacists. These are pharmacists that can work in the actual pharmacy, could be working on discharge. Depending on the intervention, they can really get more involved in stewardship. And the 5 ways we outline are verifying penicillin allergy, avoiding duplicative anaerobic coverage, reassess antibiotic therapy, avoid treatment of asymptomatic bacteria, and using the shortest effective antibiotic duration. And this is a main poster, and then we have a standalone material for each scenario that reviews more details and practical implementation tips. And also do a shout out that SIDP did a podcast with one of our speakers today, Dr. Susan Davis, and this is a great way to really learn about more implementation techniques of these 5 ways. I'm very excited to announce that this was just posted yesterday. So the hospital pharmacy posters were adapted for nursing homes. So we now have 5 ways consultant pharmacists can be antibiotics aware. And you can see here that the specific scenarios were adapted to the workflow and potential opportunities that consultant pharmacists can be involved in stewardship. And the 5 ways are ensuring documentation of the indication for every antibiotic order, using the shortest effective antibiotic duration, improving fluoroquinolone prescribing practices, avoiding treatment of asymptomatic bacteria, and then limiting the use of the prolonged antibiotic prophylaxis for UTI. And once again, this is the main poster, and then we do have standalone posters that go into more details and implementation. So this is an example of the standalone poster for limiting the prolonged antibiotic prophylaxis for UTIs. The next core element is action, and this focuses on implementing interventions to improve antibiotic use. And when we think about antibiotic use across the spectrum, the most frequent diagnosis leading to antibiotic prescribing in both the hospital and nursing home settings are lower respiratory tract, urinary tract, and skin and soft tissue infections. We know the treatment of UTIs is common in nursing home, likely due to inappropriate testing and treatment of asymptomatic bacteria in this population. And then respiratory infections are the most common cause of prescribing in the outpatient setting. Just wanted to highlight, this is a table that is in the updated hospital core elements, and it really highlights the key opportunities to improve antibiotic use for CAP, UTI, and skin and soft tissue infection. And it provides examples in a hospital setting to optimize diagnostic considerations, empiric and definitive therapy, including the duration of therapy. There's accumulating evidence that shorter course antibiotic therapy is safe and effective for many infections. And you can see here that we already discussed the pharmacy posters for the hospital pharmacist, but this is an example of one of the standalone that provides a scenario and really empowers the pharmacist to address the inpatient and potential discharge prescription and to optimize the duration. There's much literature that there's prolonged duration of therapy, particularly at the discharge. And that transitions perfectly in that we actually had recently funded the Henry Ford Health System to develop and implement a pharmacy-led transition of care toolkit to improve antibiotic use at hospital discharge. And on the link below, you can find great implementation resources, including a gap analysis, workflow for pharmacists, and educational material. And I'm just thrilled that Dr. Susan Davis will be presenting on this toolkit from an implementation perspective later this afternoon in one of the breakout sessions. And then also, this is also a real update in that this was just posted yesterday, and that the CDC, we had not only developed the poster focus on the pharmacist, but now we have the healthcare professionals can be antibiotics aware at hospital discharge. And this really highlights the key prescribing elements that should be communicated across transitions, especially when patients are discharged to nursing homes. And definitely hope you can download some of these materials, and maybe these are some opportunities during U.S. Antibiotic Awareness Week that you can really highlight optimal discharge stewardship. The next core elements are tracking and reporting, and we know that measurement of antibiotic prescribing and patient outcomes is critical to identify opportunities for improvement and, of course, to assess the impact of interventions. And we have electronic reporting from a hospital perspective to the National Healthcare Safety Network, antimicrobial use options. So this is CDC surveillance system that many of you are very familiar with. And we really highlight in the updated core elements that it's important for hospitals to monitor and benchmark the antibiotic use. And we have the SAAR, the SAR, the Standardized Antimicrobial Administration Ratio, which is our risk-adjusted benchmark for antibiotic use. For those that are more familiar with the SIR, it's very similar, but in the context of antibiotic use. This graphic shows a yearly submission into the NHSN AU option. This is voluntary and it's all electronic, which of course the electronic aspect can also create barriers. It's wonderful once you are hooked up to a vendor that can submit, and that so there's about 90 antimicrobials that the days of therapy that are from a numerator perspective are submitted, and then a denominator perspective also. And we're really pleased that we've had an increase of submissions since 2017, and that continues to increase over time. This is a map of the U.S. of the percent of facilities reporting at least 1 month of data to the NHSN AU option. You can see here, Illinois is 31%. The darker blue are the slightly higher percents, between 38 and 67%. Virginia is actually the highest at 67%, but we have some close followers at 66 and 62%. And then the white, kind of gray, is the lowest percent, between 6 and 20%. This last fall, this is actually one of my most favorite documents, is the SAR guide. For those of you that are familiar with the SIR guide, this is similar. We adapted it, the premise, and created a SAR guide. This is a 30-page document that really provides guidance for the development and the application of the SAR. And why I love it so much is it really provides not just all the background, but it actually provides demonstration and calculations. I'm a very visual learner. So right now, this is just an example where it goes into that the SAR, the NHSN uses the negative binomial regression for AU risk adjustment. And this actually provides a visual and of the actual calculations. Not that you need to know it, but I think it provides some context. And then this is actually my favorite part, where it actually will provide 2 specific examples. And here, this is an example of a table that shows the risk factors that were used in the 2017 baseline for the adult SAR predictive model for broad spectrum antibacterial agents, predominantly used for hospital onset infections. So we call that the BSHO. And so that's agents like piperacillin and cefepime and ceftaz and some of the carbapenems, as well as some other agents. And this just really illustrates that for the variable shown in the parentheses that will replace the variable name with either a 1 or a 0, depending on whether the factor is present. And then it kind of goes into some additional examples. So if you really want to understand how your SAR is calculated, definitely refer additional reading of the SAR guide. Another release this past fall that I'm just thrilled about is the 2019 NHSN AU Option Data Report. This is also similar to the HAI report that we adapted it for our use case for AU data. And this provides a summary of SAR distributions and percents of use within the SAR antimicrobial agent categories, so the adult, pediatric, and neonatal patient care locations. So this is our first NHSN AU data report. It's posted on our website, and we do plan to release another report with the 2020 data later this year in November with US Antibiotic Awareness Week. We often get questions of, okay, I submit and I have my SAR, but who are the other facilities that are submitting and contributing to the SAR? So within the Excel sheets in the report, this provides these 3 tables, which are the characteristics of the acute care hospitals reporting to NHSN AU in 2019. You can see on the left-hand side are the adult SAR locations. In the middle table are the pediatric SAR locations, and then on the right-hand side are the neonatal SAR locations, and it describes the hospital types, medical school affiliation, and the facility size. And this is just an example of the SAR distributions for one of the SAR categories by SAR location type. And in the report, it's one long row, but for the PowerPoint, had to divide it. And then this also is another illustration within the Excel files, in that it's examples of the percent of use within a SAR antimicrobial category within a adult patient care location. So at the top of the graph, you can see in the medical ICUs that cephalosporins and the beta-lactamase inhibitor combinations contributed to most of the use, followed by carbapenems. And then in the bottom chart, you actually look at the specific agents that contributed to that SAR. And lastly, the AU report conclusion provides best practices for using AU data for action. So it recommends to submit monthly AU data to guide tracking and reporting for ASPs. We know this may have been challenging during COVID, so if you've taken a break, we really hope you can resubmit retrospectively and going forward. And then similarly, we would really encourage you to review your data at least quarterly to track SAR and AU data over time to both inform and assess stewardship interventions. And then we encourage to report SAR and AU data on a regular basis to the senior leadership. This loops back to the hospital leadership commitment and having that face-to-face time with senior leadership or the hospital board or hospital committees and providers. We encourage you to establish facility-specific SAR target goals for quality improvement. And then lastly, to create or participate in the NHSN AU group function as part of a healthcare system, a health department, or a collaborative. And then the last core element is education. And we know that healthcare professionals know the guidelines for common infections. And what was really emphasized from the stewards when we updated the core elements is that the education is most effective when it's paired with interventions and measurements of outcomes. And so the stewards, of course, were saying that we educate all day long, and that needs to be emphasized in the core elements, and that this case-based education is really powerful when it's coupled with prospective audit and feedback and pre-authorization. And one more education is that we do have a CDC training of over 8 hours of complimentary CE credits on stewardship. We are in the process of updating and renewing CE, so there'll be updates in the next year or two on this. And then lastly, just wanted to highlight that the U.S. government had a national goal for all hospitals to have stewardship programs by 2020. And you can see we've had a steady increase in the 2019 data. We had 89% of facilities self-reporting that they met all 7 core elements through the NHSN annual hospital survey. We know that this was, of course, really encouraged and kind of some of the foundations of accreditation and the MB Equip program and conditions for the participation really emphasize the CDC core elements. And we are going to be analyzing the 2020 data in August and September, and should definitely be presenting those results during U.S. Antibiotic Awareness Week. And just wanted to highlight lastly that U.S. Antibiotic Awareness Week is scheduled from November 18th through the 24th, and definitely hope you can get involved from a global, a CDC, a health department perspective, as well as really encourage activities at your sites. And we will be releasing more information soon about webinars and partner podcasts and a lot of activities that we'll be doing. And thank you so much for listening to my update, and I'm looking forward to speaking more during the panel discussion. Thank you.
Dr. Raj, were you going to moderate a Q&A, or are you going to do that at the end?
Thank you. I think we can see how the chat comes up. It will be really nice if we can have the presenters go over their updates first. And I'm asking the attendees to, if they have questions, they can, for a particular speaker, they can put that in the chat box. And again, based on the questions as we monitor, we can take that moderator's prerogative to either interrupt in between sessions, but our preference is that we go over all speakers first and have their update. And again, Melinda, thank you so much. This is great, and I already am seeing how it will so very well connect with the core elements and some specific actions that we will be doing in our long-term care track. So hopefully folks that heard your presentation will have so much perspective into how then it becomes important and practical in long-term care. So that's my long-winded response to your your question. So we'll go ahead with our next speaker, and then again, if I see questions in the chat box that I think we should have in between sessions, I will ask. Otherwise, we will go all the way to the end, and then hopefully, since we won't have a PowerPoint, we will request the speakers, turn their cameras on, so we have a little bit of interactive, and we can see people talking, as we know that the PowerPoint and the cameras use too much bandwidth, and we are just asking folks to not turn camera on. But for our Q&A, hopefully we can do that.
All right. Well, thanks, Dr. Raj. I will then, I think Becky Dragoo is having some minor issues unmuting. So we're just going to jump ahead to the schedule and then go back. We're going to go ahead with the ADA update right now. And
so I wonder if Becky is having the same issue as Dr.
So we're going to, we're going to just go ahead with the schedule, and then we'll go back to Becky right after the ADA update. So at this time, I'm going to introduce, I think it's Malavika, Tampi, She is the manager and methodologist for the ADA, Center for Evidence-Based Dentistry. Her interest in evidence-based healthcare began in graduate school at the University of Michigan's School of Public Health, where she learned how clinical practice guidelines have the potential to dramatically improve patient care through the implementation of safe and effective treatments. Over the past 8 years, she has developed international, award-winning guidance through various projects focusing on the appropriate management of dental decay, use of antibiotics in dentistry, and evaluation of oral cancers. Additionally, she has consulted in medicine in the fields of vaccination and cardiovascular disease prevention. Her work specifically includes the development of systematic reviews, clinical practice guidelines and textbooks, teaching clinicians and other methodologists the fundamentals of evidence-based research and practice, and extensive stakeholder and patient engagement. She has collaborated directly with international clinical, policy, and methodological experts, including those from the CDC, the Cochrane Collaboration, and the Pan American Health Organization. It is my absolute pleasure to introduce to you Malavika Tampi. Thank you so much.
Hi, thank you so much for having me. Can you hear me?
Sure can. You sound great.
Awesome. Thank you so much for having me again. My name is Malavika Tampi. I am representing the ADA Science and Research Institute. As I was so kindly introduced, I am a manager for the Center for Evidence-Based Dentistry, and today I will be speaking to you all about antibiotic stewardship-related policies across organized dentistry. A few disclosures about me. I have no financial conflicts to disclose. I represent the ADA SRI. I am also faculty at the University of Michigan School of Dentistry and a member of several other groups like the Peggy Lillis Foundation, Guidelines International Network, and IADR, Evidence-Based Dentistry Network. It's a premier dental research organization. A few objectives today. I would like to explore with you all why and how antibiotic stewardship-related health policies are developed generally, especially in the context of associations. I'm approaching this from the perspective of clinical practice guidelines and related clinical policies. I would also like to review relevant policies published in dentistry specifically, and also discuss strengths and limitations of existing policies. So what is the problem we're facing in dentistry? 10% of antibiotic prescriptions are written by dentists, and 30 to 85% of these are suboptimal or not indicated, which is really important to consider when we're creating policies and clinical practice guidelines. At the moment, there is one evidence-based guideline that exists for antibiotic use in dentistry, and there are several actual policies and guidelines, but when I say evidence-based multidisciplinary guideline, what I mean is that there was an expert panel or guideline panel informed by a systematic review of the best available evidence and also engaging patients and stakeholders in the development of the guidelines recommendations. The panel itself was made up of pharmacists, experts in epidemiology, emergency medicine, and obviously dentists as well. And this was a wonderful group to work with. One of the speakers later in the day was one of our panel members. So this was a wonderful project for me to work on simply because we had so much collaboration and expertise at the table. And the main point I wanted to make about this is that we would really like to see more of this type of evidence being created by organizations nationally and internationally, because it really allows for a broader perspective on antibiotic stewardship in dentistry. Now, how are health policies generally developed? We start with research data, as we always do. And what the intention behind that is that we would like policymakers and guideline developers like me to have the data needed to actually inform the best policy possible. So we really want to make sure that all of our guidance and policies are backed up by research data. And usually how we do this is by conducting evidence synthesis or systematic reviews. Once the actual policy options or recommendations from a guideline panel are developed, we channel that through several dissemination strategies to practitioners And then these are the people actually writing the prescription, of course. And once the prescription is written, or the prescriptions are written within a particular health system or community, it's useful to get the data on how those, what those prescription practices are, what the health outcomes associated with those are, and then funnel that back up into research so that, again, this loop can continue and policymakers are working with the best available evidence at all times. Also, developing effective health policies requires constant skepticism. And this isn't skepticism like an anti-vaxxer or an anti-masker would have. This is skepticism in the context of really questioning if the path that we're following is the best path in terms of policy development and outreach and patient engagement. And also keeping, again, the research data informing these policies up to date. So what are the means for collecting new data? How is that data channeled into the hands of policymakers? And how does that actually get pushed out to the public and clinicians? So these are questions that we ask ourselves in dentistry and hope to continue to ask to create effective clinical policies. And of course, no policy, either clinical or otherwise, is really effective without political commitment. This can look like politics as we see in Washington. This can look like an organizational policy or a policy within a dental organization. And really what I'm trying to emphasize here is that you can have innovation, you can have collaboration, you can have a great technical package with research data and well-written, clear, actionable guidance. But without the political commitment to actually push this through, we're really not going to see meaningful change. So what are the criteria or the evidence that are relevant for decision making? So this is an exploration of when we're developing guidance, policies, clinical practice guidelines, what are the factors that we consider when we are making those recommendations? And recommendations are, again, clear, actionable statements for clinical practice. So providing the best care for patients. How can we do that? So these points 1, 2, 3, and there's also 4, 5, 6 on the next slide, are some of the criteria we look at when we're making decisions. So first is the balance between benefits and harms. So what are the benefits of antibiotic therapy, let's say? What are the harms of antibiotic therapy? This is collected using a systematic review methodology. I won't get into that, but I'm sure many of you already know what that is. Second is patients' values and preferences. So what are the preferences related to getting an antibiotic versus not, or one antibiotic over another? Resource utilization. What is the cost effectiveness of a particular therapy like antibiotics versus another treatment? What is the acceptability of a particular course of treatment? Again, feasibility, and these are all implementation concerns, and equity, which is really important to consider. And luckily for us, it's really, the concept of equity is really making traction in dentistry. And equity, of course, is not the same as equality. Equity is a concept that allows us to understand that everyone should have the same opportunity to get healthcare and to be healthy. And so really want to ensure that in dentistry that's our final perspective in terms of access to care. So shared decision making is one concept I also wanted to cover before diving into some of the existing policies across organized dentistry. Shared decision making is a way to treat patients as partners in their own care. And this is a relatively new concept in dentistry because dentistry has always been this very hierarchical, the dentist is in charge, they have their team, and then there's the patients. And really we're encouraging dentists to, again, partner with their patients to inform their care. And what this facilitates is an opportunity for patients to really understand and accept the care that they're receiving. And this includes antibiotic therapy or antibiotic prophylaxis. And this is super important because we know that patients oftentimes mistake antibiotic use as a relatively straightforward, safe therapy versus other types of treatments. So, for example, in dental practice, we see patients that come in with a lot of dental pain or swelling, and they oftentimes believe that taking an antibiotic, which antibiotics are amazing life-saving drugs, but they also can cause harms. And that's rarely communicated to patients. And so they often think that receiving an antibiotic would be less harmful than receiving the treatment, the dental treatment that would actually help them feel a lot better, and is actually much safer when balancing the benefits and harms. So these are the types of conversations we hope dentists will continue to have with patients. And also it explains any confusing messaging with patients as well. And there's a couple resources that I've linked here. And the CDC has amazing resources, so please take a look at their pages regarding shared decision making and patient engagement. And I'd be happy to share some of these resources with you all later as well. So some big picture policy considerations that we've kind of been talking about at the ADA. I'll just cover one or two of these. When we're creating clinical practice guidelines, we usually, we always have a strength of the recommendation and the certainty or quality of the evidence associated with that recommendation. And what this really ensures is that people understand how strongly to implement or put in action a particular piece of guidance. And so strong recommendation usually means go for it. The clinician should go for that course of action in most cases, versus a weak or conditional recommendation. You may want to have a conversation with your patient. You may need to talk to other providers to really make the best decision for a particular patient. And for policymakers, strong recommendations usually mean go for it, because they're based on moderate to high quality evidence, versus for weak recommendations or conditional recommendations, there's a substantial need for debate and involvement of multiple stakeholders to really create a policy option that is effective and effective. So one example I wanted to provide is that of that we just faced in dentistry, which is when the pandemic hit, COVID-19 hit, we recommended that dental practices only provide urgent and emergency care. And this was a little bit obviously concerning for many reasons, but one major policy consideration that we had was, what should we communicate about antibiotic use during this time? Because patients with this incredible pain, this incredible swelling, didn't have anywhere to go. And sometimes this didn't fit under urgent or emergency care because it was just the pain. They weren't suffering an actual infection that needed a treatment because it wasn't likely to progress. And so what should we do with these patients? That was one of the major questions our leadership had. And one major further concern was, do we think that clinicians will actually prescribe more antibiotics during this time? And we actually weren't able to, but personally, I don't have the data associated with this. If anyone on here has the data associated with antibiotic prescribing during COVID-19, that'd be great. I believe there's a presentation later, but this was a really big question for us here at the ADA. Also, policies informed by evidence really help define research priorities, also adaptation and adoption of guidelines, because now people in different settings, guideline developers, policymakers, have the evidence and the justification for a certain policy to be able to contextualize a particular guideline recommendation or policy to their setting, which is exactly what we want to do. We don't want, there's no need for us to hold all the information. We want to be able to share that with anyone who wants to adapt or adopt our guidance. And also to consider that we work in an evidence ecosystem. There's so many players, and how can we share data amongst these players so that we can create a synergistic effect and actually have the best outcomes for our patients. One major consideration that we also wanted to bring to the table was the undesirable or harmful effects associated with antibiotics. Oftentimes when we're creating policy, we're looking at the benefits. So what are the benefits of this therapy or intervention? What are the benefits of this one compared to this intervention or therapy? And really what dentistry is starting to embrace is the consideration of benefits versus harms. And so when we're talking about antibiotic use, it was really important for us to understand what the harms associated with a particular therapy was. And some of these are listed on this slide. And this was really the conversation that we had with our guideline panel. So what are the benefits of antibiotic therapy for a particular condition? And what are the harms? And how can we weigh those and create a guidance document that best informs clinical practice? We also want to encourage the use of the CDC core elements. Of course, dental clinics are outpatient settings, and there's a great paper in JADA 2020 that lists some of the elements that are relevant for dental practice. And these include commitment to antibiotic stewardship, action for policy and practice, of course, tracking and reporting of how clinicians are actually practicing so they can self-evaluate. And also there may be tracking and reporting within communities or health systems, and also education and expertise, not only at the dental school level, but continuing education and also collaboration interprofessionally, which were all amazing points and things that we've considered when we develop our policies. So what are relevant dental policies? I wanted to provide an international perspective, national, medical, educational, as well as a state and local perspective. Again, I'm approaching these perspectives as a user. I actually did not participate in the development of any of these policies. So I just wanted to put that out there. Of course, I developed some of the ADA policies, but I'm talking about points 1, 3, 4, and 5. I'm just reporting what I was able to find during my research. So I'll start with international policies around antibiotic stewardship. The FDI World Dental Federation is the premier international association consisting of member states. And really, this is the organization that defines global advocacy and policy priorities for dentistry. And their policies emphasize knowledge, educational programs. So this was really great. Again, fits into this, what the CDC has defined as a priority. Partnering with patients, which is that concept of shared decision-making that I talked about before. They also acknowledge that along with antibiotic stewardship programs, that infection prevention and control programs are very important, and not only in medicine, but also in dentistry. NDA should actively engage in their AMR National Action Plan frameworks, and that policymakers should ensure that a robust national plan should be in place to tackle antibiotic resistance. Also, they really put a lot of effort into highlighting the importance of stakeholder engagement and collaboration across different professions, and the importance of actually publishing the evidence and the guidance or policies that are informed by this evidence in scientific and professional journals. And again, what this does is it validates whatever that final policy option or recommendation is. It provides judgments on what the evidence was that led to that conclusion, as well as who was involved. It really details who were the people making those decisions, what were the stakeholders, who were engaged, and were their patient partners included. And these are all criteria that journals look for when publishing these types of documents. The ADA, which is obviously a national association here in the United States, has identified several conditions in dentistry that would require guidance. And of course, when we create effective policies, we want them to be clear and actionable. And so they need to be specific to a particular dental condition. And as you can see, we have more dental conditions than we know what to do with, and that actually may require an antibiotic to treat or prevent. And really, we've only touched on the prevention of prosthetic joint infections with patients with prosthetic joints, and the treatment of pulpo-periapical related dental pain and swelling. There are several other areas we would like to explore. Like I said, we are in the process of getting there, but there's a lot of work to be done, and we would love to share this workload if there are other organizations or groups, methodological groups, guideline development groups who really want to develop guidance on these other conditions. In our effort to create guidance on dental pain and swelling, which I just mentioned, we engaged multiple stakeholders, and these include not only dentists, but again, pharmacists, emergency medicine physicians, and we also talked with public health professionals and professionals from SHEA and ITSA, and this was such an amazing effort because we were able to get perspectives from not only within dentistry, but the greater healthcare community, and this really helped us for multiple reasons. And I'll specifically focus on the American College of Emergency Physicians. Emergency physicians, EDs, are the a huge prescriber of antibiotics for dental patients. And this makes perfect sense, right? Because dental patients who can't access a dentist at a particular time at night, or because they don't actually have dental insurance or can't afford a dentist, go to an ED. And what are the channels that an ED physician has for actually referring a patient to a dental clinic? Sometimes none. And how do they treat a dental pain and swelling? Sometimes they don't even know how to diagnose dental pain and swelling appropriately, because that's usually not within their scope of practice, and they really shouldn't be treating those patients. And so oftentimes what happens is that an antibiotic prescription is written. And we really wanted to address this issue with ASAP. And amazingly, they were able to not only participate in our guideline, but endorse our guideline and disseminate this endorsement to their membership. And we thought this was an amazing collaboration and really effective in channeling the data and the recommendations from a guideline panel to not only dentists, but to other healthcare providers as well. We've also partnered with other associations like the AHA and AAOS, which are American Heart Association and Academy of Orthopedic Surgery, to create guidance. And we always did this by providing expertise to their writing groups and really being able to gather information back from them and disseminate that to our membership appropriately. Of course, we can't look at dentistry without dental education, and that is ADIA. Which stands for the American Dental Education Association. And this, the work that ADIA has done was really interesting. And because what I found was that they not only provide recommendations, policy recommendations, but they actually detail specifically documents to use when creating institutional policies. So they cited ADA guidance on antibiotic prophylaxis, the antibiotic therapy guideline that I just mentioned for dental pain and swelling. They provide students with in-depth guidelines on, they suggest that dental schools provide students with in-depth guidelines on appropriate antibiotic prescribing, which was amazing. And they also encourage continuing education, and also, like I mentioned, partnerships with between dental schools and ERs. And I thought that was very, very well thought out by them, and something that I hope to see more of in the future amongst dental schools throughout the country and local EDs. And their main takeaway message was that by educating and training the future dental workforce in antibiotic prescription guidelines, academic dentistry will be part of the solution in combating the growth of antibiotic resistance. And I know UIC has done a fantastic job of this, so kudos to the entire UIC dental team for taking this on. Finally, but not least, there's no perspective that matters really if it's not connected to state and local perspectives. And ASTDD is the Association of State and Territorial Dental Directors, and they have multiple components to their policies, which include training and education, providing links to toolkits, as well as encouraging monitoring and feedback. And this is some of the language from their policy. And what I really wanted to emphasize is that they're promoting not only provider education and public education, but also suggesting the monitoring and evaluation of prescribing practices and processes. Also, they suggest that state and territories can play a critical role in interdisciplinary collaborations and implementing effective ways to engage healthcare providers. And this is super important because, like I said, we can have these global policies, these national policies, but without actually having collaborations at the state and local level, there's no way we can move the needle on antibiotic stewardship and appropriate prescription of antibiotics. I also wanted to explore some intersecting strengths of these existing policies, and these are some of the main ones I identified. Many of them, if not all of them, encourage collaboration interprofessionally and within the profession. They promote increased awareness for patient partners and engaging patient partners. They really promote frameworks set by the CDC, so they're not just creating frameworks, they're really identifying existing frameworks and building into those, which was fantastic. They reference evidence-based policies and they support actually the creation of evidence-based policies, which was very interesting to see because dentistry has been resistant to evidence-based medicine. And more recently, within the past 15 to 20 years, there's really been awakening, I would say. And so it was wonderful to see. And they also provide emphasis on state-level monitoring and evaluation and on dental education, which is critical to continuing the cycle of effective prescribing practices in the dental world. Some potential gaps of existing organizational policies are general or vague commitments. You may have seen those kind of interspersed within my previous slides. And this is really important to consider because policy options and guideline recommendations should be very specific and actually provide means to automatically track and improve performance, if not also to provide actionable guidance on how to provide care. And so there's all of these components that are working together to actually improve health outcomes, and all of those should be detailed in a way that users of that policy should clearly understand what to do. They have identified elements that are both they haven't appropriately identified elements that are both highly effective and scalable. So how can we move from just a clinician and an individual to a greater population? That consideration I found missing, and something that we really should and will be working on over time. Also, there was limited technical and actionable guidance, as I mentioned before. And technical and actionable guidance can look like appropriate antibiotic prescribing for all relevant health conditions. So all of those different conditions I showed should ideally have a guideline associated with it. So an evidence-based clinical practice guideline or policy recommendations associated with it. Also providing technical actionable guidance on first-line versus second-line antibiotics. And as our previous presenter, Dr. Neuhauser, mentioned, also details like when an antibiotic can be stopped. And one of the main priorities of our last guideline was to ensure that we included that detail, that after 24 hours that an antibiotic could be stopped if there was a resolution of symptoms. And so this was really critical for us to include because it's actionable. We gave a time frame, we told them exactly what to do, and we also supported it with the best available evidence. Other ideas for technical and actionable guidance look like detailed delayed prescribing strategies, and also the fact that I mentioned earlier about harms not being considered and detailed within documents, actually specifying these harms of inappropriate and also appropriate dental prescribing and how to communicate this to providers, patients, and within the community. Other existing gaps include lack of clarity about sustained political support. So what is the political support really pushing these policies forward? That's a bit grainy and something that we should be really considering in dentistry. Also, consistent pursuit of collaborative efforts. Across organizations, there's really this push, right, to collaborate. But how does that happen? What are the avenues that these different organizations, different players within a particular community or sphere can really pursue? We really aren't clear on how that can be done. So that's another priority within dentistry, something that we really should be pursuing, not only at the global stage, but at the national, state, local stages as well. And this can look like an emergency department partnering with a local dental clinic or a dental school and actually creating guidance that can make that a reality, not only in one particular setting, but that's scalable to other settings as well. Finally, there is a reliance on state and local communities to implement programs with limited financial and technical support. This is something to consider for future policy, and obviously access to care issues, always an issue, and something that really can't be solved with clinical practice guidelines, really requires a lot of political support as well. So the key messages from today's presentation are that antibiotic stewardship is a big priority for dentistry and organized dentistry. We are currently setting the goal of developing clear, actionable, and up-to-date evidence-based recommendations and policies. This is very, very important for not only the ADA, but at different levels within the United States, as well as globally. Innovation collaboration in antibiotic stewardship with political support can help provide the resources and perspectives needed for really moving the needle and improving health outcomes. We've really understood this point and are working, as you can see with our last guideline, to really model how this would look. and also emphasizing the importance of monitoring and evaluation of health outcomes to see if these strategies are actually working, and to again channel this in that loop I was mentioning earlier, so that really we can understand what research needs to be done, what are the research priorities, and also how do we keep our policymakers and guideline developers up to date so they can communicate to clinicians and patients what the best way forward is. Thank you very much.
Wow, great. Thank you so much. That was incredibly informative. Wow. I feel like there's so much we don't know about your the dental realm. So thank you. This is Desma again with Illinois Academy of Family Physicians. I think what we're going to do right now is we're going to jump ahead and go to our expert panel Q&A time, and be fingers crossed sending all of our good AV Juju vibes to Becky Dragoo, who's trying to get online and unmuted. So in that spirit, I am going to just provide an introduction to Becky, so hopefully she can join us for the expert panel Q&A. She is the one who is to be doing our regulatory update. So Becky currently serves as the Deputy Director of the Illinois Department of Public Health's Office of Healthcare Regulation, overseeing IDPH's Bureau of Long-Term Care, its divisions charged with inspecting our hospitals, medical facilities, and assisted living facilities, its Life Safety and Construction Division, and Administrative Rules and Regulations Division. Whew, that's a lot. Becky previously served as the division manager of the Illinois Department on Aging's Home and Community Services, as well as worked with the Attorney General's office as a nurse paralegal, and at Memorial Medical Center as a cardiac surgery nurse, and as a supervisor of field operations for the Illinois FOP Labor Council. Becky lives in Springfield with her husband, who's an attorney, and at this point, I'm really wishing he was an AV specialist, but hopefully she'll join us. She has a passion for dance and music and the flower gardens in her backyard. And she also lives with her dog named Books. So at this time, I'm going to pass it over to Dr. Raj, who I introduced earlier, and he'll be moderating the expert panel Q&A, and in hopes that Becky joins us. So take it away, Dr. Raj.
All right, so we just saw Becky's little box pop up. Becky, you want to try one more time to see if you can unmute yourself and maybe do your regulatory update? We'll give it a couple of seconds. And again, as we mentioned, Dr. ZK actually was doing her little update when we kind of cut her right through with this, because of, I am guessing, the way the platform works and the scheduled sessions. I was listening to her, and suddenly this session popped up, and Desma, you just came right in. So hopefully we can ask, and if Shannon is listening, to see if our group, in between sessions, can have her back. And I'm just making a little small talk for a couple more seconds to see if Becky's, because she was, and she just disappeared again. But if she does pop up, we will. So in the meantime, again, Melinda and Malavika, thank you so very much. Again, for listeners, this is Raj Mahajan. I'm an internist and geriatrician out of Chicago Oak Park area. Been involved with this group from very beginning, and it's just such a pleasure and honor, and just humbled by the way this group has evolved. We have over 500, I think, or just about 500 people registered. And I remember when we did it the first time, we pretty much were all hospital and acute care folks coming in and speaking about best practices and the future and the presence. And over the period of last several years, we've just seen it evolve. And I'm so very proud to see that our long-term care attendees have outnumbered. And I'm a little, partial there because my research and academic focus is in post-acute. So really proud. Everybody from post-acute, long-term, non-acute care setting need to pat their back to see how we've grown and how we have worked on this. And then again, I remember a couple of years ago saying, hey, how about dentists and dental, discipline, and inviting the group for the first time a few years ago to having this evolved and just the depth of policy making and evidence that Malavika, you have just described. It was just fairly gives me so much just hope that you all are working and that our dental practitioners would carry on with the work that we have done, and just delighted and super impressed with what you have presented. So I am going to ask. So Melinda, you did an overall kind of umbrella presentation on stewardship and data around it and some of the processes that are in place at CDC level. And we will, coming up, talk about how important it is to have some of that during transitions. So especially folks going from hospitals to nursing homes, or from number one, and number two is folks going from nursing home to the emergency room, where we all talk about to be not very technical, ball getting dropped. I just would like for you to maybe tell us a little bit about what's your distilled reflections on hospital to nursing home transfers, and some stewardship barriers or successes we've had recently.
Great. Can you hear me?
Yes.
Okay. Yes. Thanks for that question. And absolutely, transitions of care are utterly important in all sense. Like you said, the ED to being admitted, from being discharged to home or the nursing home. And I think that's why we've really been trying to focus on discharge stewardship and funding the Henry Ford project. And what's really neat about that, not to steal Susan's thunder later this afternoon, but it was created not only from a large tertiary medical center, but also applying the principles of discharge stewardship at community hospitals where there may be less pharmacy services, because her specific implementation was a pharmacy-led discharge stewardship. And I think that also is why we transitioned and to create that poster that I just mentioned for healthcare professionals to be antibiotics aware at discharge. And it goes through, I think the first step is, of course, is assessing, does the patient even need an antibiotic at discharge? Was there sufficient length of therapy in the in-hospital setting? And then if so, then you don't even need the discharge prescription. And then if not, then what is the optimal amount of therapy at discharge? And then what you're really honing on is really how to enhance the communication from the inpatient service to the nursing home or any of the other healthcare professionals that are managing that patient. And I think that's really why we tried to highlight and that discharge, that enhanced communication, as well as that's through, of course, documentation and really spelling out the specifics of why the patient is on an antibiotic, what was the inpatient regimen, was there any cultures, what is the anticipated length of therapy in the outpatient setting, and, of course, what side effects, or monitoring that should occur. So I think those are some of the aspects that we really want to try to enhance patient care with those transitions. From your perspective, do you have anything else you'd like to add?
No. I think it's very helpful. I just to hear these thoughts, and I am 100% sure that the reason why the chat box is not just blowing up is because a lot of people are having trouble really getting used to the platform, listening to the session and watching the slides, as well as the little chat on the right hand. So I'm by default representing folks that I know that we live and breathe in both hospital and in post-acute setting, and so I mean that's very, very helpful. And do you and I again, not wanting to really go near the hornet's nest right now, but do you in all candor tell us a little bit more about how NHSN as a platform is being utilized, and again, both hospital side, where we do have evolved IT structure, where a lot of data could probably come out of the electronic health records that are fairly well integrated, and can submit automatically using submission IT submission platform, i.e. somebody does not have to log in manually. And correct me if I'm wrong, if I'm assuming that, and then you in keying in some of the important data that then you can use to really compare performance and improve overall outcomes. How is that going for post-acute setting, and also for acute care setting overall, using NHSN and leveraging its just national presence as a single platform to track the data elements, and then use it to improve the overall outcome, which is judicious and appropriate use of antibiotics and cutting down the bad outcomes?
Yeah, that's a great question. And so I'll answer it in the context of the NHSN antimicrobial use option. And that focuses on only the hospital setting and what we call select outpatient. And that's really only the ED or the observation status units that are, quote, outpatient. And so at this point, we have about 2,100 facilities that have ever submitted to AU. It's more of a population type metric in that we collect days of therapy. So if one patient received vancomycin 3 times a day or 1 time a day, it would contribute to 1 vancomycin day. And then we have a denominator of days present as well as admissions. And facilities submit electronically aggregate monthly data, both for the patient care locations as well as what we call the facility-wide inpatient. And we are really focused on enhancing the usability of NHSN and the resources for NHSN. That's why I was really excited this last year. We were able to released the SAR guide to really solidify the foundation of understanding of the SARS, as well as our first report for the NHSN AU option with the 2019 data. And it is, really only based on voluntary submission with a few exceptions. The Tennessee Health Department does have, I don't want to call it a mandate, I don't know their technical terminology, maybe a regulation that is going to be starting soon for the largest hospitals to submit, and then there'll be the medium size and then smaller hospitals. And then Kentucky also has AU reporting quote mandate or regulation, whatever their technical terminology, and that can be either through manual or NHSN AU option can be a resource for that. And then, there's other healthcare systems such as like the Department of Veterans Affairs. If they have greater than 30 beds, then they do require submission as well. And, facilities are using the data to really track antibiotic use, as baseline and post and intervention. And one of the kind of new features we're hoping that will be released in the near future. Honestly, it was supposed to be released this last December, but because of COVID, NHSN has been really focused on COVID priorities. So some of our kind of standard bread and butter type of stewardship features have understandably been delayed, but we're calling it the Targeted Assessment for Stewardship, or the TAS. And this is similar to the TAP, the Targeted Assessment for Prevention, if for the IPs out there, and that we're going to be able to provide more details on the days of therapy that you would need for a reduction. So, for example, if your SAR is 1.7 for the resistant gram-positive SAR group that includes Vanco and some of the other agents for VRE and MRSA, then you can target within the NHSN application at your own facility level. So maybe you think based on an MUE that you conducted a medication use for appropriateness that vancomycin is inappropriately being utilized, and you think based on some internal data that you could target a reduction to 1.2, then the NHSN application through reports and a dashboard will inform you how many days of therapy reduction would be needed in order to achieve your target. So super excited for when that will be released. We also are releasing a graphic that once again was delayed in light of COVID, but it will be able to track SARS over time, which I think facilities, of course, already do that through the export function, but that will be nice to have it within the NHSN AU function as well.
Thank you so much. And as I promised, this group is not a shy group, and that we're going to have fireworks, and I think we're getting ready for those. So I know we can't afford another IT technical snap here, but I am going to ask if the speakers don't mind, because we don't have a PowerPoint up, so I think we can pull it off. If you don't mind, and we understand if you can't, but if you don't mind turning your cameras on, so our over 400 people can see you and have more next to best thing of being in front of you in the front row. So if the speakers don't mind turning your cameras on, I'm trying to do that myself. And also we do have a few questions here. I am going to go out of order. So Katie and Deb, so let me please take the moderator's prerogative and select the order in which I'm asking questions to the speakers. So we have the first question that I am going to ask, and this is for you, Malavika, is from Stephen Sylvester, and he's asking, as you see in the chat, I'm going to read for folks that are that are probably not in chat is you mentioned the data point here, 30 to 85% is suboptimal or not indicated. So very likely so. And the question is, what action steps for dentists to review current practices and to see if that data can be improved a bit?
Yeah, so the question was that 30 to 85% of antibiotic prescribing in dentistry is suboptimal, and how can this be improved? Was that the question?
Correct.
Okay, so there are a few steps that I would consider within a particular setting. First would be to understand what are the prescribing practices. So how are dentists within a particular setting prescribing antibiotics? What are the conditions they're prescribing for? What type of antibiotics are being prescribed? And monitoring that, recording that over time, and then understanding what the guidance is. So what are the appropriate prescribing practices for those particular conditions for that particular population? And then the second step after that would be, or the third step after that would be understanding who are the key stakeholders in that decision making. So not only are there dentists, but are there others in the community that are influencing those prescribing practices? And how do all of these people work together? And finally, how can we make that change? So what are the stewardship practices? What are the actual policies that you may be wanting to implement in a particular setting? I know, I believe her name was Deb, put into the chat something specific to long-term care facilities. So what are the specific challenges associated with patients within a long-term care facility? What are the appropriate prescribing practices, and how would those relate to people within that facility? Who are all of the providers working together to make those decisions? These are some of the questions you may be able to ask yourself when trying to improve antibiotic prescribing practices from inappropriate or suboptimal to appropriate. And again, harms associated with antibiotic use exist whether the prescription is appropriate or inappropriate. So also considering how do we communicate those when prescribing an antibiotic, whether it's appropriate or not.
Thank you. That was right on point. So you asked, answered both questions, and we might actually polish that question a little bit more for you if we have time. So that question, which again, both Katie, your questions are loaded, and hopefully, there are a few more sessions with experts in that field coming up for the rest, and I will remember that and hopefully re-enter those questions with those experts. So the question, and I was there. If you see my bio in early, in mid 2000s, started as a solo practitioner, was renting space, and wasn't part of a big outpatient group or hospital system. And literally, what I had was what I could get, and on a shoestring budget, and just renting a few hours a week outpatient clinic to start. So the question is, so is that what about clinicians that are on their own, the solo practitioners or one or two physician group practices that don't have those big corporate resources to implement some of these policies? Is there anything from CDC or elsewhere we can tap into? Or if I understand, if you can't particularly answer that question, is there a way or place we can guide our folks? And again, thank you, Katie, for asking that question. It's so very important because I do see in the hospital, as hospitalist group, some of the folks coming in, and again, I don't have data to this is just my experience. So maxes out at anecdote level is that a lot of times those folks coming into the hospital complication are from the community physicians as well. So anything you can tell us about how can we empower those small practices or solo practices?
Is this a question for Dr. Neuhauser or? Dr. Mahajan, you're on mute.
This is for community physicians, and so Melinda, if you have any thoughts on that, and as I said, if you don't have a lot about that, maybe as I said, we have a few sessions coming up later where we might have appropriate expertise to answer that.
Answer it from a stewardship perspective. Thanks for the question. And of course, the setting. So in the outpatient setting, we have a lot of resources, and I can actually put it in the chat. Our patient resources as well as resources for physicians that can really support the outpatient independent practitioner in terms of decreasing demand. The classic example is for potentially a parent that is seeking antibiotics for a viral infection. So we have a lot of resources for that, posters and education, as well as we have educational material in the dental setting, as well as in the inpatient and the nursing home. And I think what I would encourage you is constantly to continue to look on our website, because we are constantly reviewing the material and updating it. But prior to COVID, we actually message tested many of our material for key individuals. For example, we test some of the material with dentists, as well as patients or parents of caregivers, or a lot of different scenarios, as well as hospitalists. And that's based on that finding, we revised our material to really be the most impactful. And then I think from an inpatient perspective, I would obviously encourage, really get to know and collaborate within the inpatient structure. So if you're maybe a hospitalist that is working the overnight shift, there are opportunities to work with the stewardship team and maybe work on some of the transitions from and documentation of patients on antibiotics, or you can get involved in many different aspects. I think stewardship programs are constantly wanting to collaborate. Typically, sometimes they just don't know who would love to be a champion. And so having a champion that is, that is working in a different setting within the hospital, or have different responsibilities, or have a different perspective, they can really work together to collaborate to provide resources or structure for those more independent practitioners. But thanks for that question.
Yeah, and as I said, thank you everybody for jumping right in and letting me know that I was blabbering off while muted, and I answered that that is the holy grail. One day we all will figure out when to speak when you're unmuted, and not speak when you're muted. So that still is. And so Malavika, I know Melinda, you touched on dentistry a little bit there. Is there anything additional, Malavika, you would like to add for smaller solo practices that in dental setting that this might be from your end additional?
Mm-hmm. No, I think that answer was fantastic. And I just wanted to add that patients in a rural setting or in single clinician settings are no less complex than in other settings. So we're still seeing or facing the same issues in a rural community or a single clinician community versus another one. And so really there has to be, regardless of the type of practice, an understanding of the best prescribing practices. So there is some, I think most clinicians, regardless of how big their setting is, have access to policies developed nationally or statewide, so they can access those resources. But more practically speaking, they may not have the community, so that collaboration within that local community to actually implement effective change in terms of stewardship practices. So there may need to be some collaboration with, let's say, a local dental school or a local hospital or other specialists in the area to ensure that the patient care being provided to a dental patient is holistic. It's considering all of the different providers that they're seeing, not just that single dentist that they're going to. And obviously, in terms of greater change, broader change, there needs to be increased emphasis to local policymakers to address this issue specifically. So how are solo clinics in rural communities or in other communities, non-rural too, really approaching stewardship practices? So how can we support these folks to actually implement effective stewardship strategies and really help move the needle in those communities towards appropriate prescribing? So understanding how those clinicians are practicing, providing the resources to affect change, and then measuring those outcomes, like I said, to ensure that they are then getting the resources that they need based off of whatever those implementation concerns are.
Thank you. So couple things now. I think first thing I do stand corrected, and so when we mentioned physician solo practices, I was corrected that it's not only physicians. Yes, of course, dentists are involved in our discussion, but the fact that we need to make sure the advanced practice clinicians, the nurse practitioners, physician assistants, clinical nurse specialists, that we all include them in that discussion in rural areas and even other underserved areas. A lot of times, the advanced practice clinicians could be the only person out of an office and be the decision makers as well as have that responsibility. So yeah, it applies to all of them. The next question coming up, and again, both our speakers that are on today, a lot of times we end a discussion with that question, which is, again, it's so important, is what guidance, and this is from Katie, and is out there, which we see all the time as the reason, is that for physician clinicians, advanced practitioners that are afraid of litigation, that they're afraid if that they don't prescribe an antibiotic and the patient actually has a bacterial infection, and they are afraid of possible litigation. What resources and guidance out there that can be passed on to them to help them with that fear of litigation? Melinda, you want to start?
Sure. Yeah, Katie, that's a great question. And often we hear that as a reason why you want to err on the caution of prescribing an antibiotic to ensure you're treating an infection if it's there. And, from a CDC perspective, I'm not aware of any specific guidance that we have on this topic. I know there's been lectures on this topic and published literature and whatnot, but yeah, I can't point you to any specific CDC guidance on that.
Thank you, Melinda. Malavika, from your end, is ADA or anything from that? Do you have any guidance or any literature?
Unfortunately, I would have the same answer as Dr. Neuhauser. The ADA doesn't really get into the litigation component. We focus on creating evidence-based policies that, again, are kept up to date, and so clinicians have all the information that they need to make the appropriate clinical decision for a particular patient. And usually, again, engaging with patients, providing all of the information on the benefits and harms, really just talking to them helps prevent a lot of issues down the line. So just my 2 cents.
Well, absolutely, that's very helpful. And so, again, maybe if I rephrase that question, and I'm not, I think I have, or we have an idea on the response, but litigation as the supreme fear is always there, but it is very common fear that, even if it's not litigation, it is a fear of bad outcome, or what if I missed it and it turns out to be this. For example, in our post-acute nursing home setting, is we hear that about UTI, and in that person does not meet the criteria, and a lot of clinicians with just quote unquote dirty urine would want to throw antibiotics, because what if it's an infection, and the next thing you know, the person is going to be in hospital, and questions like that, for which we have really as physician group try to address and discuss it at all the events on stewardship, on clinical guidance. And so it was just a question. It per se, it doesn't have to be litigation, but somebody's fear, as if what if they missed it, and it is an actual bacterial infection that needed antibiotics. So and I would at this time definitely tell our audience, that is listening in, if they have something that they have done, it's an interactive discussion. Please feel free to put in the chat box if there's something, a practice that you have used that we can we can see, or we can review and then discuss further. So, and I know, Malavika, you mentioned that nothing per se for litigation, but overall, just helping with the fear, which we see in dentistry quite a bit, as you mentioned several times in your presentation, is for pain and swelling, the antibiotics being used, and so just addressing that fear of missing something. Anything on that?
Yeah, I really appreciated you reframing that. So it made me think about a different perspective on this. I would say that you're spot on. I think a lot of dental clinicians have some trepidation about not providing an antibiotic for multiple reasons. The patient is asking for an antibiotic. They're afraid that the dental pain or the swelling will progress to a more severe infection that can become systemic. So there's several factors influencing how a dental provider makes that decision, and addresses their own fear about either providing the antibiotic or not. And really what we encourage, and what we've really been exploring, is the importance of again, really deciding what the most appropriate treatment would be. So if not an antibiotic, then what? And what are the chances that that treatment will have a better effect than the antibiotic? If there is a wealth of evidence showing that an alternative treatment that avoids an antibiotic is possible, that we can move forward in that direction, then we encourage dental clinicians to actually go that way. And they should actually feel good about that, because they're providing care that is known to be effective and safe versus something that could potentially offer additional harms like an antibiotic would. So baseline at this point, I know that a lot of providers may not have that information to be able to make to kind of move through that thought process and actually make a decision that they feel super comfortable with. But we're hoping that dental clinicians really understand that thought process and kind of can move through that so that they feel comfortable with the ultimate decision that they're making for their patient. I hope that that's sufficient answer.
Oh, yes, absolutely. And again, just I'm not assuming that, Melinda, from your end, anything additional and it's understandable.
No, yeah, I think.
Yeah. So we have several people ask a question. I think the power of getting together in a session like this, and when you're done, you learn something new. That is really, my take to coming to these, and so this question again is one of those questions, so that please clarify, and this coming from Rhonda Romero, the last presentation, when they mentioned stopping antibiotics once symptoms resolve versus, and I want to do air quotations here, so I'll turn my screen on. So full course, let me say, full course, versus stopping the antibiotics when symptoms resolve. Can we clarify that, and we'll again go to Melinda first, and then Malavika.
Yeah, Malavia, was that your presentation, I think?
Yes, I did mention this, and so what the guideline panel, so the experts in the field actually shared was that there's no evidence to show that a full course of antibiotics is actually necessary, and that the harms associated with taking a full course of antibiotics may outweigh the benefits. And if there is no risk for a patient's infection to worsen to a systemic infection, there's absolutely no need to finish that course of antibiotics. So within 24 hours of symptoms, signs and symptoms resolving of whatever inflammation or even a minor infection that they have with whatever treatment that they're receiving, so not independent of the treatment, but with that dental treatment, you're actually able to stop taking the antibiotic as a patient in consultation with your dentist. So we have heard, my mom used to say that once you get an antibiotic, you have to finish the antibiotic course as recommended by the clinician. But what we found in our research and in discussion with the experts is that there is limited evidence on that.
Thank you for clarifying that. And so, but what I heard you say is that, and again, if there's not proper or official guidelines on that, you can tell us that. But the decision of that still should come in consultation with your practitioner, or the practitioners just send people out saying, here's 7 days of therapy, but if you get better in 3 days, you can stop it.
Absolutely. Yeah. The key is in consultation with the provider.
Okay.
There should absolutely be consultation with the provider to ensure that the patient is following the appropriate course, which in some cases may be that they're stopping the therapy within 24 hours of signs and symptoms resolving. Okay. Absolutely. Yeah.
Thank you. Melinda, from your end, anything on that?
Yeah, no comment. That was nicely explained, the dental aspects.
Okay. So, and I can, if I were to wrap this up, and we have a few more questions on this, that there are guidelines on and this question I think came from a post-acute group, if I'm not, because the whole association is getting cut off. So I think it came from a post-acute provider or post-acute participant. So that so from dentistry, we've heard this, and so if the decision is made to stop antibiotics on resolution of symptoms, it gets done in discussion with the practitioners. I think same thing for the same thing for non-dental setting. The decision on, so there are guidelines that help us with the appropriate antibiotics for one infection, and that something that has to be different from that, the clinicians can make that decision. Of course, we need to have the evidence to do that. So we have a few more good comments here, and I just wanted to make sure we go over those. Is that Amanda Kaplan mentions that studies have shown that practicing outpatient stewardship does not result in bacterial infection missed. Now I'm going to, although that sounded like a comment, I'm going to turn that into a question and see if our experts today have anything to comment on that particular statement that was made. Is that if you practice outpatient stewardship, it would not result in higher bacterial infections or missed bacterial infections. Again, Melinda, from your end.
Yeah, that's a great comment. And typically when healthcare systems, outpatient, inpatient setting, when you're evaluating an intervention, you typically will have some outcome parameters in terms of, was there in the outpatient setting a return to clinic, an unexpected return to visit, or in the inpatient setting, was there a unexpected return to clinic or actually a hospitalization and whatnot. So we try to, of course, evaluate patient outcomes, also C. difficile, resistance bacteria, as well as readmissions and whatnot. And so, depending on the study, there's definitely published literature out there to evaluate that. Sometimes, of course, sample sizes are too small, so it's hard to actually evaluate some of these outcomes in a more robust manner.
Thank you, Malavika. Anything additional comments to that, or from outpatient setting? This again, something was a comment. I just have turned that into a question, and again, it is followed up by another comment from Amanda, which let me say that before I have you speak, is that it is also important to remember good follow-up for the patient if their symptoms worsen. And that is something that we have at least worked extensively on, that if there is a abnormal test or some symptoms that not meet criteria, there are still symptoms that need to be addressed. And if whatever is your alternate diagnosis is, that needs to be addressed. And a lot of times we go into that UTI route. We will talk a little bit about that in nursing home session that is coming up, is what you cannot just say, oh, go home, nothing's wrong with you. There are, so if it's a viral infection, that also needs, the hydration and all of those things. And again, if they're not addressed, people do get, worsened symptoms. And again, at the heart of all of this is, as clinician, we want to make sure our patients don't feel bad, they feel better, and they feel comfortable, and they know what's going on with them. And during the time of sickness, a closer follow-up and high-touch care might be the way, other than, hey, here's your antibiotic, go home and call me 2 weeks later kind of thing. So adding that comment, and thank you, that's very, very well said, Amanda. So going back to outpatient stewardship and missed bacterial infections, comments from Malavika.
I thought the answers by you both were wonderful. I really don't have much to add other than really emphasizing that point to dental clinicians specifically, that following up with patients is obviously great practice. It's not always possible for a variety of reasons, but especially when an antibiotic is written, it's critical that dental clinicians really pursue practices that allow them to follow up with these patients. I know that there is a C. difficile infections, community-associated C. diff infections are oftentimes caused by a dental prescribing of antibiotics. And the dentist doesn't understand or know, they're not aware that this patient that they treated now has a C. diff infection is in a hospital. So there's not only the risk for the patient to develop or their symptoms to worsen and to develop a more severe infection, but also for them to suffer other harms or undesirable effects associated with that antibiotic prescription. So that follow-up is very, very important for dental clinicians to understand how their prescribing affects their patients and how the patients are potentially improving based on that antibiotic prescription as well, or whatever other treatment that they pursue. Thank you.
Thanks, Malavika. So now we're getting into the weeds of this discussion, and that's why I said a lot of times that is our first question, and we have a lot of comments and questions just getting into the details of this whole process of antibiotic course and duration of therapy. And so we have Tamara Webb here asking a question, and I know, Malavika, you answered that in the comments, but I would like you to come to the mic and also explain that to the rest of the group. So the question is, wouldn't stopping the course of or the course midstream repeatedly result in increased resistance to the antimicrobial? So if I were to just kind of rephrase the question, and if I understand that correctly, is that if you have a certain course of antibiotics and you stop it in the middle, but they also say repeatedly. So, would that practice result in increased resistance to antimicrobials? And again, I think we understand the question correctly, and we're going to answer it as such. Melinda, anything to comment on that?
Yeah, I think in my presentation, it was more in the context that shorter course of therapy, such as for CAP or VAP or SSTIs, have been found to be equally effective than the longer durations. And so that's been a real focus on stewardship interventions. It can definitely be challenging at the discharge, and that's why kind of been focusing a lot in my lecture and then funded the Henry Ford project, because at the time of discharge, of course, there's a lot of moving parts, and once the prescription is written, sometimes it's hard to intervene. That being said, it's felt that these shorter courses of therapies really thought to be safer in a potential less development of antibiotic resistance, because it's really, you're transitioning to the kind of unnecessary, like we've already really treated the infection for a sufficient duration, and now this additional amount is considered unnecessary and potentially more predisposing the patient for adverse events.
Malavika, as I mentioned, that you did put your response in the comment, but would you mind please speaking to it as well?
Absolutely. Yeah. What I said was that we didn't find any substantial evidence to support the full course of antibiotics. Of course, again, I'm not a clinician, and clinicians should make the best decisions for their patients based on the available evidence and their clinical expertise. In no way am I dictating clinical practice. This is just a presentation of what the evidence says, and based on that, there was little that we found to support the full course of antibiotics, either to affect change, so to improve a health outcome, or to prevent antibiotic resistant infections. Actually, we did find some evidence that the longer you take an antibiotic, the more prone you are to develop antibiotic resistant infections in the future. So there was a lot of debate about this, and I'd be happy to review this evidence with anyone who's interested after the fact as well. And if anyone has any new evidence, it'd be very, very beneficial for the ADA and other organizations to know about this. So please feel free to share that so that I can disseminate that internally as well. Thank you.
Thanks, Malavika. And I think, and also Tamara did clarify that she is from healthcare setting, and if I may, and Melinda, this will be both comment as well as question, which we can have a discussion on. I think the concept of how long antibiotic is needed for a particular infection has been changing in the last several years, and it's all about staying up to date with evidence and best practices, and that are published, right? So we have for acute care setting, we have for long-term care setting, published guidance on if you have this infection, you use this antibiotics and for this long. And for example, you said CAP, which, so it's community acquired pneumonia, or you have UTI, urinary tract infection. For example, for pneumonia, I remember when I was a resident, I'm not going to say that was pretty long ago, but yeah, it was. So it was a 14-day therapy. If somebody needed hospitalization, they got anywhere between 5 to 7 days of inpatient IV antibiotics, and followed by another week of oral at home, and that was standard, at that time as practice. And then now we that thing from 14 days to 10 days to 7 days and 5 days, and that's all based on evidence that for your typical community acquired pneumonia. So if the clinicians are not going to, that's why it is important for people to attend the continued education and be up to date with guidance, because it is not uncommon, even in this day and age. I'm talking about 3 months ago, when I did talk to a physician who practices exclusively in long-term care setting, where I had to have a discussion, and I was told that I was wrong, that for community-acquired pneumonia, the recommendation is 2 weeks of therapy. That where did I get all this, this information, what I was talking about, that I didn't know what I was talking about. So a lot of times, if people don't keep up to date with what the current guidelines are, it is harder, and it does affect the prescription, and antibiotic use, and so So for them, or somebody who thinks that community-acquired pneumonia needs 2 weeks of therapy, for them, 5 days stopping is stopping in the middle of the course. But that is how you get the messaging out. And We're kind of in power play under 2 minutes now, so we'll try to wrap this up and maybe have a little bit of comments on how do we have this new and the places people can go to find the up-to-date guidance on antibiotic use and maybe antibiograms for local areas. Melinda and then Malavika, we will speak to that, and we're almost home.
Thank you all so much. Thank you, Dr. Raj. Thank you, Melinda, and thank you, Malavika. This was a really great expert panel Q&A. Thanks, everyone, for putting your comments and questions in there. We have a 15-minute break right now at the top of the hour, so we will see you all back here in 15 minutes at 11:15 for Melinda's presentation on antibiotic use during COVID-19. Have a great break, and we'll see you soon.
Yeah, thank you, everyone. Shannon, I don't know if you can speak on this session. If you can, we are getting repeated questions about availability of slides and the presentation. If you want to put that again in the chat box.